Everyone is following me so far. All right, so I do have a quick kind of discussion or a question for you guys. Can somebody give me a definition of racism? Who's a quick definition? And I'm hoping somebody would have this definition. You have a hand up? You guys know how to raise a hand? We got David Blair has raised their hand.
Racism is a system of oppression based on a perception of a racial difference between two sets of people. It assumes that one group of people is better, inherently, innately better and more worthy than the other.
Awesome. Thank you. It's a great definition of racism. Anyone else want to add anything to that definition, which I thought was lovely? Great. I will spare you rewriting what David just said on a PowerPoint slide. And again, some of this is coming from the assumption that many of us who are here have been talking about racism, reading about anti-racism for the last year. Maybe some of you have not. But let me assume for now that we all roughly share the same definition, which is that racism is a system of oppression based on this concept of race that differentially privileges, in our case, the case of racism, we're talking about white people over other people in the world. And anti-racism, to quote Ibram X. Kendi, the opposite of racism isn't not racist, it's anti-racist. What's the difference? One endorses either the idea of racial hierarchy as a racist or racial equality as an anti-racist. One either believes problems are rooted in groups of people as a racist or locates the roots of problems in power and policies as an anti-racist. One either allows racial inequities to persevere as a racist or confronts racial inequities as an anti-racist. There is no in-between safe space of not racist. Andrew Ibrahim, who's a physician, made this nice kind of developmental chart of the process of becoming anti-racist, which I'm guessing people have seen. Can I just, I don't know if this is doable. Can people do a little hand raise if you've seen this chart before? You know the hand raising function on this thing?
No.
Okay, the hand raising is, can someone explain? Yeah, there we go. If you go to the bottom of your screen, where is it?
We're actually not
Yes,
in
sir.
a webinar. We're on a Zoom meeting, so the reactions are just thumbs up and hand clap.
You actually can still share your screen. So
Great.
I mean, you can raise your hand, Susan, but if you want to just do it this way, that's fine. It's a different function.
I won't fixate too much on making all raise your hands. So I just wanted to get a sense of folks are familiar with this process. Now, one of the things that I perhaps will frustrate people with in this training, but sort of intentionally, is I am not, my goal today is not to give you a step-by-step how to be an anti-racist. And again, that is not because I don't think that's incredibly important. But that's because I think there's a lot of stuff out there already on how to be an anti-racist. There's a huge body of work about it. There's books upon books upon books. There's a million things out there. And if people want recommendations, I'm happy to give you recommendations. But at its core, what is being an anti-racist? It's about promoting and advocating for policies and leaders that are anti-racist, speaking out about racism, consciously opposing racism, not only in your words, but in your actions. It's everything one might imagine being opposed to this systemic form of oppression would be. And the difficulty is in the discomfort and the risk that truly being an anti-racist in a racist society requires. When we have time to discuss, again, I'm happy to be challenged on any of these assertions that I'm making. Perhaps it is not so conceptually simple. But I do think there were many anti-racists around fighting before we had books about anti-racism. It does not require an academic degree to understand what anti-racism is or to fight these systems of oppression. But the tough part's in the discomfort and the risk. And we're going to have a chance to think more about this soon. We're going to be having a little bit of a discussion. But in this first kind of passage of topics, I want to, again, review this concept of anti-racism. And then I want to get right into trauma after a few more comments about anti-racism, okay? I hope folks are following. If you're not following, please, post a question to the chat. Jessa is keeping an eye on that. And just so you know, as we discuss, feel free to interrupt me if there's something I can address. Thank you. Okay. So we've defined racism. We've defined anti-racism. I hope that is fairly straightforward. Want to speak about intersectionality. Again, intersectionality is a word that we hear a lot about. Sometimes it's a little harder to describe. It has its own history. Kimberly Crenshaw is one of the scholars, a legal scholar who really is one of the people credited with introducing the term, although the concept predates her work. Intersectionality is a lens through which you see where power comes and collides, where it interlocks and intersects. It's not simply that there's a race problem here, a gender problem here, and a class or LGBTQ problem here. Many times that framework erases what happens to people who are subject to all of these things. Sorry about that typo. And she adds, intersectionality can be used as a blanket term to mean, well, it's complicated. Sometimes it's complicated is an excuse not to do anything. So the subject matter of today is inherently intersectional. Any discussion of trauma is intersectional if you actually look at it. Those of us who are clinicians working with trauma, we know that. These themes all come in. I have never had a conversation about trauma where themes of class, gender, age, location, race, sexuality, these questions always come into people's narrative, because very often people who are vulnerable in one way or another, whether it's visible or invisible, whether it's something that is commonly understood as a form of oppression or not, are more likely to be affected by trauma. So I think that's a really important thing. And one of the things Crenshaw urges us to do, again, is to not be lazy about it. That simply because it's complicated doesn't mean we can't do anything about it. I'm guessing most of you in this space are people who do the work, volunteers, staff members at organizations, therapists, academics. Probably you are all very actively engaged in doing the work. And again, I think that's why it gets so hard, because the work is stressful. If you're working with trauma-exposed folks, you may have your own history of trauma, you may have your own struggles. It's not easy to bring all these pieces in to every moment, and yet they exist anyway, right? So that's our challenge. That's the thing we're trying to hold here.
Ranj, real quick,
Yeah.
your sound is a little bit garbled.
Oh no.
I don't know if
All right, let me see what I can do. Just a second.
And then Judy Greenberg, did you have a question? I see that your hand is raised. I don't know if it's from earlier or not. I just wanted to see.
No, it's from earlier when we were asked to raise our hands.
Okay, great. Just wanted to make sure you didn't have a question.
Thank you kindly.
Now we can't hear you at all.
I think it's that your headphone mic is just a little crackly, but if it's what works, it's
Yeah, it's not too bad. I just wanted to check.
a little
I'll
crackly.
put your headphones back on because we can't hear you at all right now. Uh-oh. Stand by, everybody.
We can hear you now, Ranj.
Can you hear me now?
Yes.
Yes? I'm audible?
Better,
Okay,
folks?
great. Sorry about that, guys.
People think that's better.
Okay,
Okay.
can somebody else say, Jessica, can you just say something to make sure I can hear you?
Yep. How's that? Can you hear me okay? Uh-oh.
All right, we may need to deal with the crackly mic.
Bear with me, guys. I'm sorry about the sound issues on my end. I'm actually having trouble hearing you guys.
It was not bad.
You can hear me, but I can't hear anyone else.
Right. I'll put something to him in the chat about it.
Oh,
All right. How about now?
Yeah.
Sounds good.
Sounds good again? Okay.
Yeah, that's a little better.
Not
Yeah.
garbled? Okay.
Yep.
Thank
Great.
you.
Thanks, Ron.
So, no, I'm sorry about that. All right. Let's get back to the screen share. All right. Okay. All right. So let's move forward to the topic of trauma and post-traumatic stress disorder. And again, if this is moving quickly, it's because what I'm really wanting to get to is the subject matter of how all these things plow into each other. And that'll be more of our time to discuss. But there will be a moment to ask clarification questions in just a minute once I introduce a couple more concepts, okay? I guess I'll ask another question. Anyone define trauma?
Mm.
I have a definition that my therapist just told me today. So I feel like I've got it like on the tip of my tongue.
Mm.
They said that trauma happens when events in your life don't match a narrative and they're not integrated or made sense of.
We have another in the chat. Trauma is a suffering that remains. Steve, did you want to add something?
Just to think of trauma as the upset from distressed experiences in our lives before they're healed.
Judy, did you have something to add?
I have something to add.
Sure.
Here's the definition I like to use. Trauma is an experience that overwhelms our brain and our central nervous system ability to process an event.
Absolutely. These are all, I love all of those responses. One, because each of you spoke eloquently about what this thing is. I think all of us, I would hazard to say, have a definition of trauma that bears a lot of truth. And most of us have probably been exposed to trauma. Good number of folks in this room have experienced trauma personally. And if you somehow have not, then somebody you love has. So this is certainly, in that sense, a universal problem. And yet, defining this term, as you also heard, even though all of those definitions kind of fit with one another, none of those definitions was exactly identical to the other. And that's where we're going to start to get into some of the challenges of this. Now, to me, the people who have written most compellingly about trauma, who have conjured trauma as a concept, have not been the clinical writers or the scientists or the academics. It's been the artists, the writers, the painters. I'm just going to share a couple of pieces. I realized that war was monstrous. If it didn't kill those it touched, it took away a piece of their souls, so they could never be whole again. And that's from Lin Fan Kuei Mai, The Mountains Sing. It's a novel just that came out recently. It's an epic saga of Vietnam in the 20th century. And thank you to Dom, who's here, for introducing and talking to me about this novel. And here's another piece of art, Trauma Number 3 by Dante Biss Grayson, who's an indigenous painter and a combat veteran. There are countless artistic expressions that capture this thing, and they're really, they're all often very moving, and I think, again, many of us can kind of connect with these descriptions. I do see a raised hand. Yes.
I have a question. Maybe you could speak to this about, I think of trauma associated with an event or an incident. So someone said, I went through this traumatic thing, and yet people are talking about, like, I'm looking at David's definition, and the trauma is the suffering that remains. So trauma is something, the same event may or may not be traumatic for everybody who was involved, but for the person who has experienced it, there's a place and time you can point to that was traumatic. But so how does that relate to the trauma that people carry with them? And maybe that's where the PTSD comes in.
So that's a great point, and that actually segues really perfectly into what I'm about to say next, which is awesome, because our minds are going in the same direction. So the challenge, right, of this thing called trauma, of which there are cultural narratives and family stories and practices that predate, Western medicine and so forth, a challenge in the framework of the European and American medical models is to distill this thing into something that we can turn into a diagnosis, right? It's a process that's been unfolding over the last 150 years, but particularly PTSD as we know it forms over the last 40 years in the wake of second wave feminism and the Vietnam War. I'm going to share two clinical definitions of PTSD. This will be familiar to some of you. These are our formal clinical definitions of trauma. These are the things we train our baby therapists when they're up and coming, or, this is the thing I go to when I have to write a report or what have you. So the DSM-5, which is the Diagnostic and Statistical Manual of Psychiatric Disorders, defines trauma. Again, this is within the definition of PTSD, a disorder. Death, threatened death, actual or threatened serious injury, or actual or threatened sexual violence in the following ways: direct exposure, witnessing the trauma, learning that a relative or close friend was exposed to a trauma, indirect exposure to aversive details of the trauma, usually in the course of professional duties, like first responders and medics. The ICD-10, which is another international diagnostic manual, defines trauma as a stressful event or situation, either short or long lasting, of exceptionally threatening or catastrophic nature, which is likely to cause pervasive distress in almost anyone. So those are our distilled, specific, not super artistic, evocative definitions of trauma that we use when engaging in clinical practice, or at least formally we use. Those may not be actually how we talk about it, and so that brings us to PTSD, post-traumatic stress disorder. PTSD describes a specific set of symptoms that can occur together after someone has experienced a trauma, usually a trauma of a life-threatening or otherwise violating nature. Now, I am not going to give you a list of the DSM-5 PTSD symptoms again. That is something that Google can do, and that is something that other trainings can do. I don't think that is actually necessary for this training. If you want them, I'm happy to give them to you, but approximately, PTSD symptoms include nightmares, what we call intrusive memories, which are memories that appear unbidden of a traumatic incident when reminded of it, and that are often laden with sensory content and are overwhelming for the person to remember. Avoidance of people, places, and things related to the trauma. Hypervigilance, which is a heightened state of alertness and anxiety that can sometimes just be pervasive all day long in some people who meet the definition criteria for PTSD. Feelings of numbness, feelings of dissociation. There's a number of other kind of key symptoms, but these are among the symptom clusters that we see defined in the DSM-5 at least. It's important to note that PTSD is just one of many possible outcomes of trauma. Not everyone who experiences trauma, even by this narrow definition, will have the symptoms consistent with the PTSD diagnosis. There are many other things that can come from trauma as well, many other types of injuries to the soul or to the mind. And there's also growth and change that can come from trauma, which is not to glorify trauma or to raise it on a pedestal, but simply to speak of the broad range of pain and healing that can come when people experience various kinds of traumas. And again, the trauma in PTSD typically refers to an individual experiencing directly some event of a particular kind. Of course, we should always be extremely cautious about assuming someone has PTSD or that they don't have PTSD. So again, If you know someone has had a traumatic experience, we cannot really assume or label PTSD. It's not really something to throw around lightly, or to assume that they don't because they quote unquote seem fine. The term PTSD is now all over the culture. It is in pop culture. It's in media. Movies and television have been exploring themes of trauma in varying ways for the last 20 years, certainly more than ever. And I hear people misuse the term a lot. I have PTSD from this training I just went to. No, you don't. So it's a term that gets thrown around a bit. But again, I'm guessing that many of you are quite familiar with that problem. I want to take a second to just quickly do a minute of question and answer. If people have any questions about just about this term, about what trauma is, what PTSD, can I clarify anything about this subject matter before we move forward into trauma-informed care? No? Awesome. Great. And then we are, so I wanted to actually do a time check with Jessa and Kate. Now we were supposed to take a bit of a break.
We do have a question.
Yes.
Lisa, do you want to ask your question?
Yeah, sure. I couldn't figure, I put a lot of hands up there and then I don't know how to take them off. Anyway, I had a question about the prevalence right now with a lot of the new research that they've been able to do with neuroscience and how our experiences affect our brain and our brain development at any age. I'm curious about how that is affecting the conversation in a clinical sense and how that is understood amongst therapists.
Can you, how it's affecting the what in a clinical sense?
I'm curious
How the neuroscience is
yeah, like like from the little bit that I've read, I find it to be it feels a little bit like the Wild West, where there's a lot of new things that are being discovered in, right now. And I'm curious about how that conversation, what that conversation is like professionally and how that's being incorporated into standard definitions.
I would characterize any conversation about psychiatric diagnosis as contentious. And I think that there is some more convergence around trauma and PTSD. PTSD is a bit more of a specific diagnosis. I think we are incorporating what we know of neurobiology and neuroscience into how we think about PTSD. Is it fundamentally changing the diagnosis? I think that depends on who you ask. And, that also gets into how is this diagnosis defined and by whom? So that is my non-answer to your question. I think there's a lag between the clinical practice and the research, but I also think that there's a real space between studying the brain on a molecular level and understanding the mind in context of the environment. And you're right, we're really in the early stages, even from the narrow perspective of psychological science, of having what I would call a truly rigorous deep theory of what this is. With that said, there are things we know, and I would love to talk more about that at some point. It would be a bit of a tangent today, but happy to talk about it with you another time, or if you want to send me a question, or if we have time later. Okay.
Rancho,
thank you so much.
Question.
Any other question? Yeah.
Can we assume that every person diagnosed with PTSD can identify, or that a therapist can identify, the event that precipitates the PTSD?
Very interesting question. That is a really interesting. Yeah.
Well, and then there's a tack on to that question about generational trauma. That's maybe not a single event, but a history of trauma.
Okay, I'm actually going to save my answer to that question because we're going to address that a little later. We're gonna be asking that together in a little bit. All right, so I'm mindful of time. We were planning on taking a break right now. Should we take, Jessa and Kate, should we take like a 3-minute just wiggle break right now and come back? Keep going?
I wonder, you also had
What
some,
do you guys think, or should I?
you had some quick breakout rooms on here. Do you want to do a quick breakout room and then folks can take a break while people's minds are running?
Yeah. Yes.
I
Or would you rather do?
I think the only thing is I did want to get into trauma-informed care before we did the full breakout. But yeah, could we just do like a get away from the screen for 2 minutes, stretch out, and then come back?
Everybody go get some water. We'll come
All
back.
right, so like
2
go
minutes.
get some water. We'll come back in like 2 minutes. Thank you. Should we get started again? Is that 2 minutes?
Let's do it.
Felt like it.
All right. Okay. Thanks, guys. Trying to be time mindful and also mindful of everyone's collective screen burnout. Okay. All right, so what I'm going to do next is I'm going to talk about trauma-informed care, this concept of trauma-informed care. I'm going to review the concept as we understand it today. It is a formal term at this point. It's not just a concept. It's something that that SAMHSA, federal government, kind of recognizes and has systematized in a particular way. And then we're going to do a little bit of a brainstorm. We're going to do some breakout groups, and I'm going to ask some questions that I'd like us to be able to discuss in small groups. Okay, so trauma-informed care. Trauma-informed care is a term that, again, these concepts, I can't describe any of these concepts as new. These are all human concepts that somebody has been thinking about since before we had this language. But the term trauma-informed care really appears most formally kind of instantiated, I guess, about 20 years ago in 2001. Not coincidentally, I think, with the beginning of the so-called global war on terror. This was developed as a response to systems that were re-traumatizing people. So in other words, for a long time, clinicians, certainly people using services in substance abuse clinics or mental health care clinics or homeless shelters or other kinds of NGO organizations were describing experiences of being re-traumatized. The most, probably maybe the most well-known example is the classic psychiatric hospital experience, which I think has been turned into a lot of art itself, still an issue. But trauma-informed care was kind of a philosophy of care that was articulated to change and transform these organizations, to acknowledge that most of the people coming through our doors are people who have experienced trauma, and we need to have a philosophy of care that makes this space secure, safe, manageable, and not re-traumatizing. That was really the biggest push. We need to stop re-traumatizing people in our systems, which are supposed to be providing care. And so in one of the early papers, which I'll mention again later from 2005, many people were referring to common procedures and practices that re-trigger trauma reactions. And so there's talk about invalidating environments, higher dropout rates, and sort of more specifically, trauma-inducing practices in public institutions and service systems, coercive practices like seclusion and restraints, removal of children, use of invasive procedures, disciplinary practices, and so on and so forth. So, of course, I would like to say that these things are not happening anymore, but of course we all know that they are. But the trauma-informed care movement has been an attempt to really, at least from within the system, address this problem that has been noted time and time and time again. And certainly if you've ever done, if you yourself have been through this experience, or you worked with people who've been through this experience, you know how these systems can be profoundly re-traumatizing. So what is a trauma-informed system? Trauma-informed system acknowledges that clients seeking services are likely to have experienced trauma in their lives. It's a system that educates all the staff and volunteers on trauma, post-traumatic stress, and effective strategies to better serve people who've experienced trauma. So again, from the bottom to the top, from the front desk person thinking of a mental health clinic to the last person you see before you move on to another setting. Trauma-informed systems implement policies, procedures, and practices that actively resist re-traumatizing persons seeking services. And they create, when possible, and facilitate active paths for people to seek care and treatment for trauma and post-traumatic stress. One of the kind of emblematic ideas that you hear a lot in trauma-informed care is that trauma-informed care attempted to get systems to stop asking people what's wrong with you and start asking what happened to you. I have more to say on that, but this is a phrase you'll hear a lot. You know, we're really wanting to move from what's wrong with you, which is seen as kind of punitive and pathologizing, to what happened to you, that understands that a person is somebody with their own context and history who has been through something. And so it is no longer about something being wrong with the person, but rather you've been through something that has affected your behavior now. And all right. Trauma-informed care can look like a whole number of things. I'm kind of going to, I'm not going to read through every one of these. And my guess is that we can all think of ways that trauma-informed care might play out in our own systems. But again, if there are questions about what this means, or if this is confusing, I'm happy to talk more about specifics. 6 key principles of trauma-informed care, again, is articulated by SAMHSA, which is the Substance Abuse and Mental Health Services Administration, federal agency. Safety, trustworthiness, and transparency, peer support, collaboration and mutuality, empowerment, voice and choice, and cultural competence. So safety refers to ensuring the physical and emotional safety of everybody seeking services or interacting with the organization. There's an emphasis, or hopefully an emphasis, on making the interpersonal interactions with staff and volunteers psychologically safe, non-re-traumatizing, and supportive. Safety is kind of the highest priority in this system. The basic idea is that if we're not producing some kind of psychological safety, we can't possibly hope to help somebody heal or access any other services that they're seeking. Trustworthiness and transparency. So an attempt to, trauma-informed care calls for organizations to be transparent about their operations and their decision-making. And there's an emphasis on the organization and the staff and the people within it building trust with clients served. So again, this is an attempt to break some of the what we're seeing as more authoritarian methods of control, which is to say that you don't have to trust me, but I will control you and I'll punish you if you don't listen to me, which is in some cases the ethos of pre-existing systems. Peer support is another principle of trauma-informed care, and that simply means incorporating people who have been through it themselves, people in recovery from trauma, to work with others who are working on recovering from trauma. Collaboration and mutuality, again, some of these kind of overlap. But collaboration mutuality proposes to partner with clients and people seeking services to demonstrate that everybody involved in the clinic has an active and participatory role in decision making. It stops short of saying trauma-informed care is radical democracy, because it's not, but it's an attempt to democratize these systems. And in practice, you do see ways in which patients or clients and staff can make decisions in ways that they didn't previously. Similarly, empowerment, voice, and choice, an emphasis on self-direction and self-advocacy, which again, we can touch more on later. And finally, cultural competence. So this is where we see, at least in the most kind of standard descriptions of trauma-informed care, this is where our oppressions are mentioned in point 6. The organization actively moves past cultural stereotypes and biases, offers gender-responsive services, leverages the healing value of traditional cultural connections, and recognizes and addresses historical trauma. And again, we will talk more about and hopefully critique these ideas. But again, I want everyone to think, I want us all to be thinking dialectically. So my purpose here is not to now tear apart trauma-informed care or say it's bad. Trauma-informed care is wonderful. I have participated myself in a number of interventions with organizations, helping them be more trauma-informed. It's a valuable contribution to how we practice care. And there's some problems with it, or there's some places I think that it could withstand some critique. So we're going to move into to our breakout groups, because I think it's time for people to get to talk to each other. I am going to share in the chat, or in a minute we'll share in the chat, the document, a Google document. Actually, Jess or Kate, could you share that? All right, so in the chat is a Google document that is a very, very simple document. Everyone should be able to access it if you click on it. It is just a list of group numbers and the same 4 questions for each group. We're gonna have you break out into groups in little Zoom breakout rooms and discuss these four questions. So these questions are: in what ways do you think might defining and diagnosing trauma and PTSD serve our anti-racist practice goals? How might that be helpful in being a better anti-racist? In what ways might those things fail to serve or actively interfere with our anti-racist practice goals? In what ways might trauma-informed care serve our anti-racist goals, and what ways might it fail to serve or interfere with our anti-racist practice goals? So you are all going to break out into rooms. Your group number will appear at the top of your screen. I think if you hover your mouse over the top of your screen, you'll see your group number. And I'd like you to pick one person in your group to be a scribe, and just write your notes and your answers under your group number and the question for the group. Hopefully that is clear. Again, I made the document, it's a crude document, but hopefully it's workable for everyone. So
groups.
Shall I break?
We have 10 minutes.
Okay, great. Thank you.
Mm-hmm.
It's good when we don't want to leave our chat rooms. That means we're engaged, right?
Yes.
Yeah.
Right.
It is good. It is good.
It's a good chat room.
Are we all back? Is that everyone? All, whatever number of people we have?
I think so. I think we are all back.
Okay. Okay, great. So rather than do the classroom thing of have everyone report back on their answers to each question, I would just, if whoever wrote or people from each group, or not so systematically, if folks could just comment on, just share what you discussed, just generally, what kind of things emerged for you, what things were, what was easy to talk about, what was a little harder to think about. Or any other thoughts you have.
You can raise your hand or put your name in the chat if you'd like to share, or put a comment into the chat. Judy?
I was thinking about the question of trauma-informed care, and thinking about, you know, I'm going to be part of a volunteer team with a new family coming to Brattleboro, and just how we as a team can really work together to provide trauma-informed care for the volunteers, for the for the families, and to really think about what are the ways that we can really embody those principles. So that's what I was thinking about.
Sure. Thank you, Judy.
Lisa, did you want to share something?
Yes, there I am. Sorry. I don't know, unless Beth, our scribe, wants to share. I was just going to say that we were kind of discussing through the questions, and then we got to the last one, which was the one that probably could have used the most discussion, but then we were out of time. So the part that I'm excited to hear from everyone about is just that I think our group was having a harder time answering the fourth question, and I'm curious about how everyone else answered it, or what their discussion was about the fourth item on the list.
The fourth one being how trauma-informed care could actually work against our anti-racist practice. Because we were pretty good at figuring out, this is group 3, how diagnosing trauma and PTSD could be helpful, and also possibly stigmatizing or generalizing and enforcing of stereotypes. But when we got to trauma-informed care, it seemed like the intention of TIC is good in the sense that it helps us modify our own behaviors toward people's behaviors whom we might not understand, and also takes away or hopefully takes away our ability to re-hurt someone. But that was, the crux was, how does TIC actually work against anti-racist practice? We all put our hands up and said we didn't know.
Someone in our group did come up with a good example, I think, of that, is that if a white shooter automatically gets trauma-informed care, or at least sympathetic look at what was the background of this perpetrator. It's not an example that has to do with us necessarily, but think of the young man in Georgia and how he was treated by police.
Had a bad day.
He had a bad day. Where it didn't have much to do with anti-racism in that case. Whereas if it had been a black shooter, or in even the next shooting that happened, I think it was a Middle Eastern background guy, he didn't get that same kind of sympathetic, what might be called trauma. And I'm sure the cop in Georgia wasn't really practicing trauma-informed care, but he was at least much more sympathetic.
Sure.
So that was the example that was given in our group.
I don't think being sympathetic is the same thing as being trauma-informed, and especially when you open your mouth and anti-racist and racist stereotypes come out. That's not trauma-informed care.
No.
No,
David, did you?
But they were looking at the person rather than what he had just done. At any rate, it is a difficult question.
David, did you have something?
Sure. Our group agreed that it's progress to move from what's wrong with you to what happened, but also felt that what happened can be an intrusive question Someone may not be ready to talk about what happened. And Jonathan, who works in restorative justice, brought up a question they often ask, which is, what do you need? If trauma-informed care, I'm sure it goes beyond the question, what happened, but what do you need is really a deeper question, and probably a more important question.
Yeah, in our group, if I can inject a little bit here, we just focused on question number 2 because we were group 2. So we thought, well, that was our job to examine that. We didn't look at all 4 of them, but I think we all.
It's a good question to focus on. That's great.
Yeah, it was. And there, one of the things that, well, a bunch of things came out, that it's important not to be patronizing, that understanding is a good thing, not to categorize. And we all said that this was, examining this question was new for all of us, but Dora was talking about how communication is really key, and that you need a two-way conversation to make sure that we're considering what we can learn from the other people, and thinking of our asylum seekers. But the power dynamic is an important factor to think about, and others from our group can add to that. But
I want to bring up something that Connie has put into the chat. Defining trauma can be a slippery slope. Trauma can be culturally defined or culturally relevant. We bring assumptions based on our culture that end up in judgments. And the language of TIC comes from our culture here in the United States. Right. Applying this language to those from other cultures may be problematic. The language of TIC doesn't touch on strengths. We leave out strengths, and when we leave out strengths, we miss something very important, and we need to bring more humility to our interactions. Tell me more. Francie also says listening is very important.
Yeah.
Thank you for those thoughts, Connie and Francie. Kai, did you have something? You need to unmute yourself.
Our group did not talk about the questions because there were several people in the group who work with asylum seekers and really are seeking support for how they can provide a loving environment for the people they work with without re-traumatizing them, and how to deal with symptoms such as hypervigilance and disassociation and things like that. In other words, we were really wanting on the ground kind of support for what we do with asylum seekers.
Right. Hopefully we'll get some of that, Kai. Sue Davis?
Yeah, can you hear me?
We can.
The thing that really struck me that I'm coming back to is when the definitions can open up a sense of empathy with someone, caring about them. It seems like that's a helpful thing. And the ways that it closes down empathy, like thinking, oh, I already know about this. So the opposite of curiosity, it seems like that's a place where it can be a problem. They can be a problem. So just add that.
I'm going to do a time check. Kate and Jessa, what do you think? Should we, I know there's more people with their hands raised, but should we plow forward?
Yeah, and I'd love to hear a little bit if you have responses, some of your more thoughts on these questions around what you were thinking when you asked them, or whatever you
Absolutely. Yeah, absolutely. So what I want to get into is I'll kind of share my thoughts about really more the critical side. So first of all, everybody's thinking in the right direction. These are all great responses. I certainly want to affirm again, kind of trying to think dialectically. My basic sort of thesis here is not that the diagnosis of trauma or that trauma-informed care are bad at all. And in fact, trauma-informed care in particular is quite wonderful. It is also the dominant, I would say, dominant like ideology of the moment. And I think sometimes when something is the dominant ideology of the moment, just the way we do things, the way we assume things need to be done, we miss stuff. And often the stuff we miss is by omission. And for those of you who mentioned some of the more some more critical perspectives on trauma-informed care, you noted things. It was less, some of it was about how this is being applied or how this is being purported to be applied. But some of it is about what's omitted. And that's something I'm going to kind of speak about. And again, in raising all of these critiques, what I'm wanting everyone to do is to first take the step of being very uncomfortable with your position. I do also, and I do quickly want to speak to the person who mentioned wanting more on-the-ground support. I'll say at the end of this, that's actually a conversation I'm happy to have, and I'm happy to have more individualized conversations about the nuts and bolts of what people are directly experiencing. This is sort of step one, which is I want people to have a framework to think about this stuff. But and certainly for CASP folks, there's, I think, a window for us to have a more in-depth, organization-specific, clinical, practical discussion. So hopefully this is the first of a couple of conversations, the next of which could be more specific. So I'm going to move forward, okay, into really just thinking about some of the critiques that I want everyone to be kind of thinking about and wrapping your heads around. If you think they're nonsense, that's good, challenge them. I want us to be asking these questions. So when I was very excited about doing this stuff I think about all the time. And in my kind of research for this presentation, I was looking up anti-racism and trauma-informed care. And there's a lot of stuff out there about being trauma-informed, anti-racist, which is wonderful. And a lot of stuff saying, yes, trauma-informed care and anti-racism fit right together. And they totally do. And there are more questions I think we need to ask. And usually it's not practitioners, or I think sometimes it's not practitioners who are asking these questions, because we're usually in a state of crisis with our clients and patients. We are in a state of, I need to help this person now. I don't want to sit here asking these like critical questions, problematizing things. Let the academics do that. I need to actually help this person, which is true. And also, I think in our state of crisis, we miss things that are important, which is also why I think these previous generations of institutions re-traumatized people, because they also thought that they needed to solve a problem immediately, which they did, and they were omitting a lot of other things. So it's both things at once, which is hard. So some critiques that some critical questions that I want to ask. First, about the trauma and PTSD question. And I think a lot of you spoke to this, and it sounds like this was we were more able to wrap our heads around why diagnosing trauma or defining trauma in this way might be a challenge. And of course, the first question is where does historical and political context fit into our clinical definitions of trauma? Does it matter? Is racism a trauma? By the DSM-5 definition, we cannot call a history of enslavement as a trauma. It is not a trauma, according to that definition, which I think we would all agree is somewhat absurd. But just 1 second. Sorry. I gotta plug in my laptop. Sorry, guys. So by the DSM-5 definition, we just can't address historical trauma. It's simply not in there. Now, many of us, perhaps most of us in clinical practice, intuitively have slid the definition in how we actually work. So I think probably anyone here who's a clinician acknowledges historical trauma and will talk about it. But the book actually doesn't let you do that. If you go by the book, it just doesn't fit. And while there is a lot of research and dialogue about race-related stress, race-related trauma, the current definition doesn't capture that. And when you get into practice, and just to say not just practice of clinical care, but needing to diagnose somebody in order for them to be able to move through a system more successfully. So for instance, if somebody's compensation from a government agency or from the state depends on having a diagnosis of PTSD, draws a pretty sharp line as to who qualifies and who doesn't. And that can have real material consequences.
There's a question here about gender-based trauma. Is that
Mhm.
included or no?
Right. So the definitions of trauma that I shared, they the contemporary definition of PTSD came from two historical streams merging. One was kind of the Vietnam veterans kind of movement, and from the feminist movement identifying trauma related to sexual assault and rape, second wave. And so I think in the political context of PTSD did indeed come from a place of addressing gender-based violence, but again, certainly doesn't address the structure. It doesn't address historical trauma. It doesn't address forms of violence that are not physical. And this question of who gets to have PTSD is really important. I think somebody mentioned, maybe in our group, the question of, as we've all seen when there's a white mass shooter, the discussion about their mental health immediately pops up. One of my favorite comedians is named Hari Kondabolu, and he has a joke about how when we talk about white mass shooters, everyone's talking about their mental health as though suicide bombers are perfectly mentally healthy and doing great, right? It's clearly their mental health. There could be mental health issues for anybody who chooses to engage in certain forms of violence or not. But the point is that we don't talk about it. Some people don't get to have PTSD. So a lot of this, as you're noticing, is about who gets excluded from the diagnosis. I'm mindful of time, so I'm just gonna pop these questions up here and have you guys take a look at it. So these are the kinds of critical questions that I think we need to ask about the diagnosis, the act of diagnosing, and you guys have actually all spoken to that. There's questions around inconsistency with cultural beliefs. I also would say that there's question marks about when I diagnose you with PTSD, am I foreclosing you for other options of healing? If you come to my office and say you have PTSD, the solution that I have is therapy, 12 to 20 sessions at this point of evidence-based psychotherapy. Not everybody practices that way, obviously, and I'm not saying I do, but are there other ways to heal? Can we validate other ways to heal? Are there other pathways to healing that the label of PTSD prevents us from accessing? And I think we can get more into specific examples of this, but I want to move forward to thinking about trauma-informed care. So trauma-informed care, I think, again, like folks we're speaking to, it is a little more consistent with how many of us currently think about providing care. I think many of us are critical of previous models of pathologizing and diagnosing, certainly of re-traumatizing systems. But I think that the trick in this question is around what's omitted and also what actually happens on the ground. So, and my first question is, there's a lot of talk about transparency and power relations and democracy and so forth. But if you look at a trauma-informed care system, and even at the materials that I shared with you, and I can give you a cheat sheet on it if you want, does it actually change power relationships between different actors in a given system? If I'm the clinician who is in charge of determining whether you have a diagnosis of PTSD or not, do I actually have less power over you if I'm using less pathologizing language? Is that actually changing my power to determine whether or not you're going to be able to feed your kid or be authorized to remain here or be treated in a certain way in a system? I would suggest that it requires more thought going beyond simply what trauma-informed care proposes to begin to alter those power relations, and in fact, perhaps makes it harder for us to see those power relations. When our language is softer, when we're all nicer, it can very frequently be a way to distract from a power relationship. If you know me by my first name, Ranjit, not Dr. Bhagwat, you're forgetting that we're not friends. And I say that, and I say that, from experience, perhaps others can think of experiences you've had. This happens all the time. Another question to ask is, can any institution be trauma-informed? What happens when a trauma-informed institution is actively part of the system of oppression, like a hospital run and staffed by an occupying army or a clinician working in an immigration detention center, which is not to say those clinicians are bad. That is not what I'm saying. That is not, in fact, the challenge of this is that there are many really wonderful, lovely people working in all kinds of settings. Some of those settings are actively oppressive. Can you be trauma informed? Can I be a trauma informed physician after the same army I'm a part of bulldozed your house? Can I really be trauma informed? The question maybe is a bit absurd, but if you if you do a Google Scholar search, you will find trauma-informed applications of all kinds of stuff. There's trauma-informed prisons, there's certainly trauma-informed medical clinics run by occupying armies. I mean, all of these examples of, I think someone mentioned the police, whether or not they're trauma-informed. Lots of police forces have lots of trauma-informed care trainings. It's not absent. One of the great critiques of some of the reform proposals in 2020 was that reforms for many police departments just haven't worked. There's been many attempts to soften the language used, to educate more, and they don't always change the kinds of violence that are visited upon people. In other words, what I'm saying is it's not that it is bad to be more trauma informed, but there are things it doesn't address, right? And again, things where the resources and the energy going into one topic can pull us away from another subject, which is the broader structure, which needs to change. Okay. And I'll talk about this last question and we'll move on. I think you guys are catching the drift. Finally, the question that I would say is cultural competence, does that item address racism? Does race-related trauma fit into the framework? Some would say it does. There are many, again, like I said, integrated kind of fusions of anti-racist practice and trauma-informed practice. And the reality is there's a truth to that, right? So I think probably most people can look at the bullet points that I shared about trauma-informed care and say, okay, here's ways where we can really use this to individualize somebody, to move past stereotypes, and to be more empathic. But I would suggest in a lot of ways that it misses some things. There are ways we can be empathic and still stereotype, pathologize, and any number of other things, which I think we discussed. We are at 8:30, so I think I will. I want to just share one story, and then that I think actually highlights this. I have a whole number of other things we could talk about, but I want to share the story of the CSR, and I'll give you context for this. So in one of the early papers on trauma-informed care that was written in 2005, the paper is based on a study of multiple service provision settings, substance abuse clinics, mental health clinics, domestic partner violence shelters, and the researchers partnered with women utilizing these services to kind of do this participatory action research study, which then the results of which produced one of the first sort of 10 principles of trauma-informed care white papers. That is a pretty important paper. It's a lovely paper. It's very useful to read. Again, if anyone wants all these references later, I'm happy to give them to you. One of the things, however, you notice in these early writings, this is in the early 2000s, is that the language used for the client or the patient or the person seeking services is this word consumer. That is the language used for this person. Now, I don't know if you guys are in systems that use the term consumer currently. I've been in a system that describes people as consumers. I am not currently. I don't use that term myself. But that is a term that was in fashion for a while. So here's an excerpt from that paper, which I think is interesting, and I would love to, I'm just curious to see what you guys think. So the paper says, when an organization integrates consumers in designing and evaluating services, it not only creates a better program, but also provides an empowering growth experience for the consumers involved. Consumers who experience the combined effects of substance abuse, mental illness, and violence have not had input into the services that are supposed to serve them. Consumer input was an essential and required part of this study. The first input women offered was that they were not satisfied with the title consumer. Some women preferred survivor, and some prefer to be called recovering women. An empowerment approach suggests that women have the right to name themselves and that diversity is strength. Therefore, in the context of this study, women name themselves consumer survivor recovering, CSRs. Can anyone tell me what might kind of be an issue with this triumphant declaration at the end of this paragraph? Anyone have thoughts? Maybe a problem here?
The first thing they said was they had a problem with the name, but they didn't change it.
Yes, they didn't change the name. They're still consumers. This drives me up a wall, so forgive me for getting too animated, but this to me is such a perfect illustration of absolutely well-meaning, really important contributions to the way we work. This paper is indicative. It's in a really important moment of change in our practice. It brought to light all these issues. This paper and the folks who wrote it are wonderful people who have helped us change the way we practice. And this is one of the most disingenuous displays of like pseudo democracy that I could see in this paper. They're still called consumers. All the women said, we hate this. I know these conversations. Nobody likes the term consumer. I mean, again, debate me if I'm wrong, but that term makes my skin crawl personally. I don't like it. Not all the terms are bad, but consumer is a particularly galling one for me. And I am not surprised that people didn't like the term consumer. And indeed, they're still consumers. But the sentence is, the women named themselves consumer survivor recovering, which they literally didn't, at least not according to this paragraph. I will leave that there. There's more we can explore about this. I want to make sure we have time to talk and just have an open discussion. I want to make one last kind of, I'm going to give one last thing here, one last set of core principles. I had a big messy list of stuff about anti-racist and trauma-informed practice, and I just thought I'd show you what's happening in my head and what I've been trying to distill here. It has been surprisingly hard to find a pre-existing framework around trauma-informed anti-racist practice that also incorporates some of the contradictions here and some of the problems in both of these concepts, or at least in trauma-informed care. Usually these models just fuse them. So, this is an incomplete set of 4 core principles that are very important to me that I'll share with you now, and then I just want us to be able to have an open discussion about all this, okay? These are 4 core principles that animate, for me and other folks that I've worked with, an ethos of anti-racism, anti-oppressive practice that is also trauma-informed. And some of this may be familiar, some of it is an integration. So education and intent, emotional and interpersonal discipline, acceptance of contradictions, and solidarity. So by education and intention, this is something I think we are familiar with, because that has been in the culture very much, being relentless in your study of history, understanding all these things about unconscious bias, so-called, and the intersections of oppressions, and all of this, some of this has to do with the volumes and volumes of writing and trainings and stuff that we have out there. Use those trainings, educate yourself, be informed on what your clients, patients, people you're working with are going through, know the context and the history, know your position, understand where you sit in history, where are you located, what role are you playing, and of course, set your intention toward practicing better, toward being a better anti-racist. And it's again, it's such a trite way for me to put it, but I actually think it's the most important piece. I don't think you need to be a scholar of anti-racism to be the best anti-racist, anti-oppression fighter there is. It's about a commitment and an openness and a curiosity and a willingness to listen and learn. That's what I think this piece is about, and to relentlessly practice that. It leads me to a second point around emotional and interpersonal discipline. I think this is really important. I think it is critical to decenter your personal journey, depending on who you are, especially. Now, your personal journey may be the same journey as your clients that you're working with. You may be somebody who's 2 steps ahead of them in the asylum seeking process. That's that's a different story, right? Your personal journey is not going to be that decentered. But if you are a white middle-class suburban dweller who is not in danger of being displaced in any way, then it's very easy to engage in this work as though it's about your own personal growth. And of course it is. Your personal growth is relevant, but that needs to be decentered if you're going to be truly committed to dismantling structures of racism and to being trauma informed, because I don't think we can be trauma informed when we make each person a project or a story for our own kind of personal narrative. Part of this also is working to show respect, building trust and safety, and not feeling entitled to be invited in or to be friends. I think this is really critical. Again, integrating trauma-informed practice and anti-racist practice. You don't have an invitation, and that's okay. But it does take a certain amount of it. What I would say, again, I hate to use such the term discipline. I couldn't think of a better term, because that's how I think of it. I don't mean to be so martial about it, but it is a certain kind of discipline to say, I feel very drawn to this person. I'm drawn to this person's trauma. I'm empathic. I want to help them. I want to know their story. And I haven't been invited, so I need to stop. I need to wait. I love the question somebody asked, what do you need? What do you need is such a beautiful question to ask. And sometimes you can't even ask that, but it's a much better question than what happened to you, right? I think practicing some gratitude of just your ability to do this work and to be in the position that someone might share their story. And the other piece of this would be to accept the storm of your own emotions and to mind your vicarious trauma. And I'm happy to talk more about vicarious trauma. If you are working with trauma exposed people right now, you probably have some quote unquote secondary trauma. You are affected emotionally by the trauma of the people you work with. And we have to care for ourselves. It is not a matter of self-indulgence. It's a matter of just, you'll shatter if you don't, or you'll hurt other people in your life. So that's that point. Accepting contradictions. And for me, I'll be short about this one. You may be both the healer and the oppressor. And nothing you do can change that. That does not have to be a bad thing, but I think it is important to acknowledge that sometimes you are going to be in both roles. You are simply going to be in both roles, that we can do everything we can to be anti-racist. We can try to decolonize our practices, decolonize the way we work, but decolonizing actually means getting the land back. So unless we're doing that, my parents, I'm second generation Indian immigrant. India didn't decolonize by changing the text code. It decolonized by taking the British out. That's it. So, there are limits on what all of this stuff can do, and that's okay. That doesn't mean any of this is bad. We should be anti-racist. We should be trauma-informed. We should be all of those things and acknowledge that even as we do all that, we may be sitting in that contradiction of also being a source of oppression. And finally, solidarity and revolutionary love, which again is an ethos, a way of being. We can talk more about that, but I want to save time for us to have a discussion. So I'm just going to leave up two quotes from Angela Davis, a quote from Angela Davis and a quote from Valerie Kaur. Angela Davis says, everyone is familiar with the slogan, the personal is political, not only that what we experience on a personal level has profound political implications, but that our interior lives, our emotional lives are very much informed by ideology. We oftentimes do the work of the state in and through our interior lives. What we often assume belongs most intimately to ourselves and to our emotional life has been produced elsewhere and has been recruited to do the work of racism and repression. To me, that quote captures this thing of contradiction, right? This thing of the way the work needs to happen on multiple levels. And on a positive note, Valerie Kaur, who is just wonderful, said about revolutionary love that it's a wellspring of care, an awakening to the inherent dignity and beauty of others in the earth, quieting of the ego, a way of moving through the world in relationship, asking, what is your story? What is at stake? What is my part in your flourishing? Loving others, even our opponents, in this way has the power to sustain political, social, and moral transformation. This is how love changes the world. I share that because, again, I really believe that when it comes down to it, better practice is built on commitment to simple but difficult things. And I think revolutionary love is maybe the most important one of those things.